Welcome to the final session. On the agenda today, the topic of this session is research on family planning and improving opportunity, which has come up several times today, and now we'll focus on it specifically. We have three of the best people in the nation to discuss this vital topic. Immediately to my left, Martha Bailey, who's a professor of economics and research professor at the Population Studies Center at the University of Michigan. She's also a faculty research fellow at the National Bureau of Economic Research. Martha conducts research on issues related to economics of gender and reproductive health. Kristen Moore is a senior scholar at Child Trends, where she's been for many years here in D.C. She studies adolescent development, including adolescent sexual contraceptive behavior. And then Jason Lindo, one of the people who came from far away. He's at Texas A&M, but he came from Bozeman, Montana. He doesn't like the temperature in Texas. I have two offspring in Texas, and I was there a couple weeks ago, and I'm on your side. So Jason is a professor of economics at Texas A&M University and a research associate at the National Bureau of Economic Research. His research focuses on effects of changes in access to reproductive health care. And there's more information about all these, all the participants in your materials. Each speaker has 8 minutes, followed by questions from me and then from the audience. And then finally, after we're done, Belle will reappear if she's still awake and come on up and give us parting words. I want to remind everybody, including the speakers, that you need to stay neat. These are wonderful mics, but you got to stay close to them. If you're far away like this, it'll be much more difficult to hear. And the one up there is the same way. So you need to be quite close to the mic in order to make it work well. So let's begin with Bailey.
Hi, everyone. Thanks so much for organizing this session. I've been working on reproductive health care since I became an economist in 2005, minted with my PhD. And I couldn't be more excited that this topic is kind of entering into the public discussion much more than it was recently. So a couple of things. We've talked about this. Everyone's seen this. Almost half of U.S. pregnancies are unintended, and those rates are much higher among disadvantaged women. So when I started as an economist, I was sort of shocked. When I started thinking about this topic, I was met with a lot of skepticism in economics. And I think many of you know what I'm talking about, not necessarily in this room, but outside of this room. Can policy really matter at all? What does this mean? And to put this in the parlance of economists, Belle set me up well to do this. Economists will talk a lot about the demand for children. So unintended births is all about what women want. And so contraceptive technology, policy, access, this doesn't really matter so much. Unintended pregnancies, this line of thought says, is kind of like an unintended speeding ticket. You know, clearly you were doing something that got you there in the first place. On the other side of that policy debate are a number of people who say it's about supply, it's about access to services, it's about empowering women to realize what the number of children they want, to actually get there. So given that they want it, how are they going to actually achieve that? And that's really what contraceptive technology and a lot of policy can do. And so one of the difficulties here, and when I entered this discussion, these were basically two different camps fighting with one another, arguing about the interpretation of a time series. So the number of births women were having, was it going up, was it going down? How do we know those changes in birth rates are not reflecting demand? How do we know they're reflecting supply? And both camps made different arguments about why things were really, really important. So my role here, I think, on the panel, and what a lot of my early career was devoted to, is how do you find good ways to put numbers on some of the things we've been talking about? I think everyone in this room thinks these things are important, but as an economist, how important? How much do these programs cost? How do we quantify some of these benefits that often appear in sort of doctors' offices and waiting rooms, in these personal discussions that don't kind of leak out into the public space? How do you put numbers on those things to try to make, sort of think about how cost-effective these investments could be? And notice I just call these investments, which is one of those ways I'm trying to shift the discussion about the cost of reproductive health care, instead thinking about them. It's like, what are the returns to a dollar spent on reproductive health care? So a couple of things that researchers do, and something I spend a lot of time thinking about. How do we get good control groups, right? When you have a policy that rolls out to every place in a state, how do we come up with an adequate comparison group? What would the world have been like in the absence of the policy? That's really what we need to do to try to quantify those benefits. The other thing is a lot of the evaluations really focus on short-term metrics, right? What people are saying at the time they get access to their contraceptives, whether or not they're getting a particular type of contraceptive. And one of the things we're really interested in are those downstream outcomes. How does access to a LARC today not just influence your life, your educational attainment, your career, the lives of your children? We want to know all of those things, right? Not just contraceptive use, but the reason we often focus on these short-term metrics is because that's the data we get. That's what we get in real time, and that's easy. So a couple of things I want to take you through. I've done a lot of work on this topic. A lot of my work is centered on the 60s and 1970s for two reasons. One, it's because we can come up with some really nice comparison groups to try to wrap to get some numbers, very clear numbers out of that. The second reason is we can start to look at a lot of those downstream outcomes. Not just how does this affect your life this year, your pregnancy this year, but your longer-term career prospects and, importantly, the lives of your children, right? So that's what I'm going to be talking to you about today. And the other thing I'm going to do is give a plug for a very large-scale randomized controlled trial that we're doing in Michigan right now that we don't have results for yet. And I think after that, then we'll talk about two of the other more recent things. So the first thing I did, so it turns out how much do laws, or you say barriers to access, matter? You can think about barriers as legal barriers. You can think about them as transportation barriers, spatial barriers. How much is it going to cost you to go and get contraceptives? Well, it turns out in the 1960s and early 1970s, women who were under the age of 21 and unmarried were not able to legally consent to birth control pills. They couldn't go into their private providers. They couldn't go into their college clinics. They couldn't get them at all. And there were a series of legislative changes that happened across states that altered those barriers. So it turns out that allowing young women to legally obtain contraceptives at 18 versus age 21 not only reduces birth rates, which is what I'm showing you in this picture right here. You can see it really drives down birth rates between ages, say, 18 to 21. But one of the things that you don't see in this figure, and I had to cut a lot out for time, if you're interested, you can go to my website and see all of these things, is it increases their educational attainment, it increases their labor force participation, and their wage rates are about 8% higher by the age of 40. So substantial improvements. That's an annual increase. So an annual number. Another thing that was important, and Belle brought this up this morning, it turns out when the birth control pill was first introduced in the 1960s, about half of the states in the United States made it illegal for physicians to prescribe or pharmacists to sell contraceptives. So one of the things that happens over the course of the 1960s is that birth rates are declining everywhere in the United States. The baby boom is ending, which was sort of the 50-year high in birth rates in the United States. So birth rates are going down everywhere. What this figure shows you is that birth rates went down significantly faster in places that did not have those restrictions on contraceptive access, allowing me to quantify exactly how much this seems to matter. And something I won't show you, but it's in a Brookings paper, is how much this improves child outcomes. A final piece is that federal funding for family planning rolled out in the 1960s before Title X, and then with Title X to places all over the United States. What impact did both setting up facilities and reducing the price of contraceptives for a lot of low-income women have on birth rates? It turns out that before the program was introduced, the places that eventually got family planning programs and those that didn't, birth rates were changing about the same way. After the program started, we see a dramatic decline in birth rates. We think is driven primarily by reductions in unintended births. The other thing that you see is that for the children who were born to mothers with access to contraception is that their household incomes increased dramatically. We see sharp reductions in the share of children that are living in households that are below the poverty line. And we also see that children born to mothers with access to family planning are about 12% less likely to live in households receiving public assistance. And this turns out to be a really important thing because this says that a dollar invested in family planning is going to have a pretty sizable effect on public outlays for a variety of public programs, even though this is just one. So coming to the last piece, so how do these findings generalize to today? What we really want to know is that all of the exciting things that we've been discussing today, what types of effects are they going to have on families? What types of effects are they going to have on the lives of children? What about now? What about in the longer term? Well, we need a time machine or a lot of patience. So those results we don't quite have yet, but I think the evidence from the past is very suggestive that a lot of these initiatives should matter. The last thing that we're doing now is, so how do we think about access to reproductive health care now? We have started, it's currently in the field, a large-scale randomized controlled trial. It's called the Michigan Contraceptive Access Research and Evaluation Study, and this is joint with Planned Parenthood of Michigan, and the fieldwork's being done by NORC. It's funded by the Laura and John Arnold Foundation, and we're very excited because what this is doing is we don't have access to the resources to change the provision of health care, even change practice in Michigan. So all we're doing for this study right now is just making the out-of-pocket costs zero for about half of the women that walk into the clinics. The second thing we're doing is so this gives us a control group that's built in within clinic. The second thing that we are able to do is we're going to survey these women following up in both 3 and 5 years, and we've also gained their consent to track them in administrative data for the next 30 years. So we expect that there'll be a lot more exciting work to come. Thank you very much.
Chris Moore.
Thank you. Thank you. What a great discussion today. Well, I want to acknowledge that I am the presenter. I've done a fair amount of work on teen childbearing over the years, but today I'm a presenter. I was a senior advisor on the project, but Dr. Jennifer Manlove was the principal investigator. Jen's daughter has her college orientation today, so I'm presenting on behalf of Jen and Kate Welty. Child Trends cares about kids at all ages. So the focus of this presentation is simulated reductions in unintended pregnancy among Delaware Title X family planning clients after a contraceptive access intervention. In late 2014, Upstream USA began an initiative, Delaware Contraceptive Access Now, known as Delaware CAN, you've heard a lot about it, to provide women with greater access to the full range of effective contraceptives. In 2017, Child Trends was commissioned by Upstream to examine how contraceptive use among family planning clients at Title X clinics in Delaware changed during the implementation of Delaware CAN. Child Trends study focuses on the time period between 2014 and 2017, as 2017 is the most recent year for which contraceptive use data are available. After examining trends in contraceptive use in Delaware and in the U.S. overall, Child Trends input these contraceptive data into the microsimulation model, FamilyScape 3.0, to project how the unintended pregnancy rate among Title X clients may have changed based on observed shifts in method use. Approach. Delaware CAN is a statewide initiative. However, Child Trends analyses had to use data for a more limited population. Specifically, the team used the Title X data because Title X grantees consistently collect and submit data on clients' primary method use each year to the federal government, and these data are audited and made publicly available. Statewide Title X data were provided by the Delaware Department of Health and Social Services, while national Title X data came from the Family Planning Annual Report published by the Federal Office of Population Affairs. The analysis was conducted for women ages 20 to 39 because levels of missing data are high for teenagers and because FamilyScape is most accurate for women under age 40. The study team acknowledges that this was not and could not be designed to be a rigorous evaluation that could detect causal impacts. However, the team was able to compare trends in contraceptive use among Delaware Title X clients to trends among Title X clients nationwide to understand whether the findings for Delaware were unique. For instance, we know that the use of long-acting reversible contraceptives, or LARCs, has been increasing over the past decade across the United States. So the goal was to check whether any changes found in Delaware were simply part of a larger trend. As I mentioned, after examining the trends in contraceptive use among Title X clients in Delaware and the U.S. overall, Child Trends then used FamilyScape 3.0 to project how the unintended pregnancy rate among this population may have changed. FamilyScape is an innovative simulation model of pregnancy and family formation. The model was originally developed here at the Brookings Institution and is now a collaborative effort between Brookings and Child Trends. FamilyScape is designed to replicate real-world fertility-related behaviors and outcomes among U.S. women of childbearing age. And FamilyScape has been widely used by researchers to examine how changes in contraceptive use are linked to reductions in early and unplanned pregnancies, births, and abortions, and there's more information on the Child Trends website. Okay, several limitations of the study, of course, deserve mention. First, the Title X data from Delaware had a substantial number of women who were missing data on contraceptive method, approximately 40% of women in 2014, and about 1/4 in later years. Needless to say, the team excluded these women from analyses. However, based on discussions with staff at Delaware's Department of Health and Social Services, we have no reason to believe that data are missing in a way that might systematically bias the results. Also, Child Trends conducted a number of sensitivity checks, making different assumptions about method choice among women with missing data. In all of these data checks, the findings were similar. Second, FamilyScape is a useful tool for estimating whether contraceptive use trends could lead to reductions in unplanned pregnancy in the absence of actual pregnancy data. However, FamilyScape is a simulation model, so it is not designed to capture causal impacts or replace a rigorous evaluation. And third, findings from this study are for Title X family planning clients, so they're not generalizable to all women in Delaware. So, results. Delaware can focused on providing women with access to the birth control method of their choice. However, one of the key findings that we highlight here was an increase in the use of LARCs, and this is important because LARCs are highly effective contraceptive methods. Among Delaware Title X family planning clients, there was an increase in LARC use from 13.7% to 31.5% just between 2014 and 2017. This increase in LARC use was offset by decreases in the use of other methods such as injectables, hormonal methods like the pill, patch, or ring, condoms, and a modest decline in the percent using no method at all. Well, among Title X family planning clients nationwide, the team found a smaller increase in LARC use during this period, from 13.6% to 19.9%. I'd like to note that these percentages are calculated among family planning clients who are considered at risk of unintended pregnancy. That is, they were sexually active and were not pregnant or seeking pregnancy. In this figure, we show the results of the FamilyScape simulations. The blue line is the simulated unintended pregnancy rate among Title X family planning clients in Delaware. The orange line is the simulated unintended pregnancy rate among Title X family planning clients nationwide, predicted based on the methods used by these women in each year. The study team found a decline of 24% in the projected unintended pregnancy rate for Title X clients in Delaware between 2014 and 2017. In the U.S. overall, the projected decline was approximately 3%. In conclusion, while this study cannot determine causality, Upstream's work with Title X providers in Delaware has coincided with a large increase in the use of LARC methods among Title X clients in Delaware, a far more substantial increase than was estimated among Title X clients nationwide. And based on changes in the Title X method mix, the FamilyScape model simulates a substantial decrease in the unintended pregnancy rate in Delaware during this period, while the national unintended pregnancy rate among Title X clients is estimated to have dropped less notably. Thank you.
Jason Lindley.
Great. So today I'm going to be presenting some joint work with Andrea Kelly, who is a PhD student at Texas A&M, also Annalisa Packham, who was a PhD student at Texas A&M and is now an assistant professor at Vanderbilt. In this research, we're trying to evaluate the causal effects of the Colorado Family Planning Initiative, which has been brought up several times today. One thing I think is important for me to let you all know is that none of us are in any way affiliated with Colorado. In fact, we didn't learn about the Colorado Family Planning Initiative probably until all of you did in 2014 when it made headlines. At the time, these headlines were talking about 40% reduction in teen birth rates in Colorado. And what we set out to do was to see, well, just how much of that decline could be attributed to this initiative. Okay, so a little bit more background is that this initiative involved a $23 million investment from 2009 to 2015. And all 28 agencies in Colorado operating Title X clinics accepted some of this funding. And the major impetus for this was that this was going to allow these clinics to offer implants and IUDs in addition to all other methods of contraception to low-income women at no cost. Previously, they would have liked to do so, and that's their policy, but they could only stock so many of these devices, and so they would have to ration them, basically. So in 2009, after this initiative was underway, we had 20 of these agencies offering IUDs for the first time, 16 offering implants for the first time. The larger goal for our research here is to try to understand to what degree does funding of Title X clinics matter in terms of improving access and use of highly effective contraception and then affecting women's outcomes. Okay, so how did contraception use change in Colorado after this initiative was implemented? This figure gives you a sense of what happened. In 2008, only about 5% of, and this is women who are clients of Title X clinics, only 5% were using a LARC. By 2015, as many were using a LARC as were using the pill. So this is a really massive increase in the share of women who are using LARCs following this program. Of course, as Martha pointed out, to know what the causal effect is, we need to have some comparison group to help us learn about what would have happened in the absence of this initiative. And so this next figure shows what happened in Colorado relative to other US states. And this is, again, the share of Title X clinic clients who are using LARCs. And you can see that the share rapidly escalated in Colorado. It also increased in the US, but across the US, but at a much slower rate. Okay, so this is indicative of a causal effect of this initiative pretty dramatically increasing the use of LARCs. Okay, so what happened to birth rates? To do this, again, we needed to find some good comparison group. And so what we did is we looked at other counties across the US that had Title X clinics. And we compared their birth rates to Colorado counties with Title X clinics. Okay, and that's what we're doing here. And you can see across the US, the teen birth rate fell quite dramatically. Okay, and what that tells us is even without the initiative, the teen birth rate would have fallen pretty dramatically in Colorado, but it fell more dramatically in Colorado as a result of this initiative. So it's not this entire decline that represents the causal effect of the initiative, it's this gap that emerges after the initiative that represents the causal effect of the initiative. Okay, so the statistical models that we estimate indicate that this initiative reduced the teen birth rate by 6.4% over 5 years for counties with these clinics. Not 40%, as the headlines might have led you to suggest, but 6.4%. And 6.4%, I would say, is pretty big. We don't have to say 40%. We could say 6.4% and be happy that that's a pretty big number, I think. Some of our more recent research has looked at data at a finer level, looking at zip codes, and there we've identified that the effects are really concentrated among women who are living in zip codes within 7 miles of these clinics. Okay, so for zip codes that are within 7 miles, the impact on the teen birth rate is 20%. Beyond that 7-mile radius around these Title X clinics, we can't detect effects. There may be effects, but we can't detect them if they exist. It's also the case that we haven't been able to detect effects for women who are older than 20 up until 2014 and 2015, where we start to see significant effects for older women. And that initially was quite a puzzle for us, and it's still something that we don't have a definitive answer to. But interestingly, what happened in 2014-15? Well, in 2014, 1 year before they were set to run out of funding, Colorado released their report on the supposed effects of the initiative. And then this initiative went from under the radar. And I can tell you that there were no newspaper reports about the Colorado Family Planning Initiative until 2014. But then it made international news, and then lots of people became aware of it. And then in 2015, there was a very fierce and highly publicized debate about whether or not the state was going to take over the funding of this initiative. And so, maybe this is why things seem to change in terms of in 2014-15 with the effects reaching women who are more distant from the clinics and also reaching older women. And interestingly, here I've plotted the number of insertions per client, and there's this interesting uptick in 2015, which we can only speculate as to why that might be the case, but it could have been this advertising, this publicity, or fear that the clinics would no longer be able to offer these devices in the future without the funding. So we've looked at a lot of other outcomes as well. We've found significant effects on relatively costly births, births involving very low birth weights. Those are certainly were reduced by a significant amount by this initiative. We find especially large effects on Hispanics and modest evidence of effects on abortions to teens. So wrapping up, I think what we've learned from this research is that funding resources for Title X clinics can have really dramatic impacts on birth rates for women who are living very close to these clinics. It seems like advertising matters, but one of the things that I think we need to wrestle with is how do we serve the large number of women who are outside of this 7-mile radius around these clinics if that's where the services are being expanded. And that's it.
Well, believe it or not, Jason and I did not plan this, but the first question I want to ask is I'd like to ask fairly simple, straightforward questions. And the first thing I want to ask is, how strong is the evidence that links these policy changes to changes in women's use of different kinds of birth control, including the more effective kinds? Is that evidence really strong? In some states it is, but do we believe it?
Well, I guess I would say that's why it's important that some of us researchers get out here and we share it. So I hope you all believed it. And I think throughout the day, though, folks have been presenting figures showing these dramatic increases in LARC use when they are made available to women. And these increases are so dramatic relative to what is happening nationwide that it really has to be a causal effect of the expansion in access.
I would agree. I think that the findings are so similar across studies where people are not working together, they're not collaborating, but they're getting very similar results, and that's not trivial.
All right, so we've established a fact that these policies have an impact on the The states use them and employ them, and they have an impact on the service that are delivered. What are the effects on kids?
Well, I guess that's for me from Child Trends. I mean, I don't think we have data from any of the available studies on the implications for children. But from everything we know about child development would suggest that children who are born to couples who are committed to one another, committed to their child, planning to have that child and raise it together, who are more educated and more financially secure, those children are advantaged in life, and so that is probably going to be positive. And gosh, it seems like that should be the next phase of research.
No, go ahead.
Here. So in fact, looking at the effects on kids was one of the important components of what I was showing for the 1960s and 70s, not just health, but and so what I was able to show you is changes in household resources for children that are born after family planning programs begin in the United States. So how do we interpret that evidence? There's two things that could be going on. One is just a lot of poor women aren't having children anymore. They didn't want to have them, now they're not having them. So the income on average of children born after the initiative rises. This is just mechanical. But that doesn't necessarily mean that the resources of any child that's born are actually changing. You're just taking the mean over a more advantaged group. So how do we actually know whether or not resources have improved for some of the children that are born? In fact, we have evidence on this as well. So one of the things we do in our paper is try to bound what we would call the selection effect is versus what is and what I called the empowerment effect when I wrote that paper, but the editor made me change it to the resource effect. So the way I think about the other side of this discussion, it's not just you're sort of eliminating certain children. You're empowering parents to have children in families when they want. How does this actually affect those parents? Does it affect their employment? Does it affect their education? Does it affect their receipt of public resources? Does it affect their health? And how do those resources affect their children once those children are born down the line? We actually know the answer to that too. So in the context of the 1960s, about half of the effect in 70s, about half of the effects we see are due to the selection. That is, there are poor women, poor families who are not having children. And the other half of the effect is due to what I call the empowerment effect. I'll say that in this crowd, even though the editor wouldn't let me print it. That is the lives of people who have access to family planning, in particular at Title X clinics, that their children are doing significantly better for those families. So I do think that that's very, very promising evidence. So what about, those are childhood resources. How does that translate in the long term into those children's educational attainment, labor force participation, disability, health? Those are really hard questions. I cut that slide because I was short on time, but we also have some evidence on that. So one of the things I was showing you is that we see these sharp reductions or sharper declines in birth rates due to this decrease in unintended pregnancy in places, for instance, that didn't have these restrictions on contraceptive use, right, in the United States in the 1960s and 70s. You can look at those cohorts of children, and those kids, right, kind of going back in your mind, they're about prime earning age now. So when we look at those cohorts of children that are born in those states, how much higher is their educational attainment? How much better are they doing in the labor market? It turns out significantly. So you see this both for sort of the Griswold paper that I described first, and you see this also for the rollout of Title X clinics in the United States over the 60s and 70s. So I will say both pieces of evidence. So what are the effects on children for Colorado today, for upstream today? That's really hard to say, right? We need a time machine and a whole lot of patience, right? One or the other. But we can tell from evidence from the past that, in fact, it appears that children are doing much better as a result, and measurably better in ways we can see in data.
I'd like to hear from the panel what kind of research we do. How can we supplement and improve the studies we've done so far to do something like Martha is describing? How can we find out if we agree that there are impacts, which everyone on the panel does, and that there are more wide use of effective means of birth control and reductions in pregnancy rates among the women who are using them? How can we more effectively demonstrate the effects on children?
Well, I would offer one strategy, which is the use of simulation models. And FamilyScape is, of course, one simulation model. Child Trends has also worked with Brookings to develop and now are updating the social genome model, which is a child development model. So it's looking at not just education for children, but their social development, their emotional well-being, and their physical health, and also their relationship quality. And hopefully, when that is ready, we will be able to simulate those kinds of findings. I mean, you'd love to see a long-term intensive random assignment study done like Absidarian on this kind of project. Maybe you're doing that in
Like that,
Michigan.
that's what we're doing in Michigan.
I hand the mic to you.
So one of the things that's really challenging when you're thinking about outcomes of kids is sort of one, we know that pregnancies are rare. They don't happen to every single woman. Two, unintended pregnancies are rarer. And then if you think there are effects on kids, right, that those aren't going to be massive. And so you're starting to cut your samples down to be really, really, really small. So if you want to look at the effects on kids and you're looking at all the survey data we have, you're really limited in what you can say. Statistically, you have very, very small sample sizes, but really, really rich data. So one of the things we're trying to do as part of the MCARES project, and something that I think is really important for these evaluations going forward, simulation models are the best we can do without a lot of data sort of now. But if we're trying to actually follow these kids and be able to say quantitatively in 5-10 years how well we're doing, using administrative data. Administrative data is collected on every child. We have birth records on every child. We can say things much more definitively for the universe of kids than we can for a small sample of kids. So I will encourage you, if you're putting these together and thinking about this, I do think administrative data can really help shed new light on some of these important questions.
I'd like to add that I was really excited to potentially evaluate how the Colorado Family Planning Initiative affected kids' outcomes. And along with my co-authors, we spent a tremendous amount of time trying to do that using survey data. And we can't find anything. And it's because the data are just too sparse. It's not necessarily because there's no effect. It's just because the sample sizes aren't large enough. The other thing that I would add is that, one of the things that made it possible for us to do our research was that the state of Colorado was willing to share data with us. It couldn't have been done without that. And I think this is really important for all the organizations who are implementing these sorts of programs. There are different methodologies out there that exist, and I think we would have more convincing estimates of the effects of these programs if we have multiple teams out there doing research using different methodologies, so that way we can compare and contrast the results.
I just want to mention one resource that goes beyond some of the administrative data, which is, of course, a wonderful approach. But the National Survey of Children's Health has been done since the early 2000s, and it has information across domains: health, education, family, and emotional and well-being, and offers some opportunities. It is cross-sectional, that's a liability, but it has huge samples, tens of thousands of children nationwide with state-specific samples. So that's a possibility.
Can I add one more thing? Sometimes administrative data can be difficult for researchers to access. One of the things we were hoping to do was to get data from the Colorado Department of Education, but they declined to participate in the study because they thought it was too controversial.
Yes, it's a condition of life in the United States, is that states are often very jealous of their data, and they will not share it. They won't share it with people at the federal level, and we won't share it with the Census Bureau. So that we have a lot of work to do there, and we could learn more, especially about these kind of what seem to be now correlational issues of effects on kids of these policies. All right, now I want you to be policymakers, okay, and apply your research knowledge to, I think, very important policy questions. The first thing is, I think, I've been citing this quite a bit, and been involved in a little bit through the power to decide. And that is the Trump administration seems to have, I don't want to be too critical here, but they are doing several things that are reducing funding and support for the programs that are helping the states implement and pay for these policies. So the question arises to me, are we going to have to face a situation where the states are going to be not only the main innovators, which I think they have been so far, but also they're going to be the funders of these policies, which are going to be a difficult issue for the state. I want to give you one example. Teen pregnancy prevention, which the way I look at things has been a very, very successful policy implemented in sites all around the country, competition for the money. They would now be in the 7th or 8th year of implementing these programs at the local level. Unfortunately, you showed the data on teen pregnancy and the same data on teen birth rates. They both just plummeted, unbelievable. And the teen pregnancy prevention may play a role in it. And the Trump administration decided that they were going to use the money for something else. And when I was on the Hill for many years and actually played a role in the funding for this legislation while I was on the Hill. And when I first saw this, I said, they can't do that. They cannot do that. This is a law passed by the Congress, has all kinds of stipulations in it. The actions of the agency meet the stipulations, and now they're going to take the money out and use it for other purposes. Well, they did it anyway. Fortunately, the courts intervened, and they stopped the Trump administration, but they still took some of the money, and it's a mess. So that shows you I think it shows you the strength, the evidence that the administration is really willing to move on this agenda, not just on the abortion front, but on many others as well. So the states are going to have to not just step up with innovation, but with money too. How are they going to do that?
I don't know where they're going to find the money, but one thing I would like to say is, states have innovated in this way in the past. Texas is a great example where in 2011, they cut family planning funding by 2/3. 80 clinics in Texas closed. And this is because they took the funding away from these clinics. There's really good research out there that has documented the effects of this defunding by Yao Liu, David Slusky, and Annalisa Packham. If you want to look them up, they show that preventative care use among women fell. Teen birth rates rose. So we don't have to guess about what is likely to happen if we cut Title X funding. We've seen it in Texas.
So I would say that there is another approach, which is that the savings can be invested back into these kinds of programs. And I think that's true for evidence-based programs more broadly. They've prevented incarceration in Washington state. They're not building as many prisons now. But given how rapidly some of these changes seem to be happening, they seem likely to generate savings in short order. So I might propose that as a possible source for states to fund their innovations.
In fact, at least one state I know of is actually doing that. So that's a good concrete suggestion. How states could fund it is through PROR. I think that's is a possibility. Anything else?
So I think everyone else on the panel has laid out what we know what the costs of these programs are. One of the things that I think has been important is so times are tough, budgets are tight. If you're a policymaker and you want to influence opportunity of kids, where do you put your money? So you can think about this in lots of ways. And so this is the difficult types of decisions that a lot of people are facing. And a lot of people are choosing to take it out of reproductive health and put it into other programs. One of the things I think, so as an economist, we tend to think about sort of things are sort of what are the costs, but you can also think about these things as investments. So if you're thinking about what are the returns on dollars put in public education, what are the returns on dollars put in Medicaid? And so not just sort of how much does that influence, say, the next generation's opportunities in human capital, but also is there very mechanical savings associated with some of those decisions? And I think in that sense, family planning, and I've been arguing this for a very long time, I'm on record and in multiple papers doing kind of the cost-benefit analysis, is cheap and it has an extremely, extremely high return. It's improving the environments of children in terms of resources and homes before the public sector ever steps in to help, right? It complements any investments that's happening in schools. It's also complementing a lot of the investments that are happening through the healthcare system. So in many ways, this is setting kids and families up for success. So $1 spent on family planning is maybe the best investment policymakers can make, and I can only think that some of these places that are, all of these cuts are going to increase costs in other programs so much that they may not be sustainable.
I agree with that, but it's amazing how many policymakers don't pay attention to benefit cost numbers if they oppose it on other grounds. And this is an area where they oppose things for all kinds of
Right.
bizarre
Right.
reasons. Okay, audience. Time for audience to ask questions. Raise your hand. I'll recognize you. Someone will bring you a mic and ask your question. All the way in the back.
I can't resist this question. So if they are not wanting to provide, they know that family planning, investing every dollar in family planning is a great investment return. What is your personal opinions as to why they will not invest in family planning? And does it have to do with a larger view of just women in society in general or something like that?
I mentioned the Texas experience with this previously, and there it was very clear that the intent was to deprive funding to organizations associated with abortion providers. I mean, there was, it was spoken about quite openly.
Other questions? Yes, over here.
Thanks again. I'm still Mark Hathaway from Washington, D.C. Which is still not a state. I'm curious if any of you are looking into the research. There's a lot of talk these days about maternal mortality rates rising in our country. And it seems to me there's lots of research in low-resource countries around the world that if we provide safe, simple, easy access to abortion care and safe, simple, easy access to family planning services, we can tremendously reduce maternal mortality rates. And those numbers are tough to draw down for multiple reasons, but I'm wondering if any of you as researchers or anyone is looking at that link.
So I would say internationally, yeah, and there's really good research that's being done. In the U.S., I know of some failed attempts to do it. One of the issues there is this is a really rare outcome, and so getting any estimates with statistical precision, as Martha was pointing out, is especially difficult when you're talking about an outcome like this. But perhaps with better access to measures of maternal morbidity, I think that's maybe the best shot that we might have. But I haven't seen any research in the U.S. context on this issue.
And there's one more question in front of them. Wait, Mike's coming.
It wasn't so much a question. It was just, does anybody in the room feel we have to cut taxes anymore so that we can, do away with some of these programs? Give it to the rich? It's not a question.
I looked at my notes, and Jason, can you say a little bit more about this issue of women living within 7 miles of a clinic? I hadn't heard that about the results from Colorado. Does it only pertain to women within 7 miles? Can you just say more about that? Sure.
So you may have seen one of the earlier papers on this that's published, and that was like analysis using county level data. So the next step in our research agenda was to get more granular data and look at zip codes. And so that's where it's an NBER working paper. If you're interested, we're sort of focusing down on just how close you have to be in order to observe these impacts. And it seems to be about 7 miles up until 2014 to 15. And then after that, we see effects out to 12 miles from a clinic.
So you need an Uber study.
Can let me add to this though, and I think that this is really important. When we talk about access to reproductive health care, there are the effects we can measure, and there are the effects that we can't measure. And a lot of those have to do with the sample sizes, and a lot of them just have to do that effects are small relative to sample sizes. So when Jason is saying, correct me if I'm wrong, that we can't measure effects beyond sort of these certain radiuses, that is, we cannot detect statistically that there is an effect. It doesn't mean that women aren't benefiting in driving in. But what it does mean is sort of if you're thinking about transportation, taking the bus to your local Planned Parenthood, or how are you going to catch a ride, or being locally proximate is actually going to matter a great deal for access. And so that's something that, so it does suggest that the effects are larger, so proximity is key to access. We know that. But it doesn't mean that there's no effects. We know that women drive a great deal of distance, which is also evidence that, of course, these clinics and services matter a great deal.
Mark.
Thank you. I was just wondering if you could position or help us understand the scale of the changes that you've seen, certainly in Colorado, but also Martha spoke of this a little bit also, in some sort of a comparative way. In other words, compared to other kinds of things. Jason, you said that in Colorado it was, I think, 6.4% reduction in teen pregnancy. I'm just trying to, I think all of us in this room really care about the broader issue of opportunity, and how do you think about family planning and investments in that against a whole suite of other things that one might do, whether you're talking about outcomes for kids or outcomes for mothers, just put it in a relative basis.
Mm-hmm.
Well, I was thinking how do you scale this is the question. And I think if you think about it relative to the effect size of other interventions, it's hard to change the behavior of human beings. You know, we're kind of a stubborn people. And the rapid response to this suggests that there is an unmet need, that people are ready for this, and that making it available, certainly the higher the barriers, the less likely people are to access the services. And so that this is probably, but I don't know that we're in a position to calculate an effect size, but it sounds to me like it is potentially quite a large effect size relative to other interventions. And I just might note that prevention is generally more cost effective than amelioration or treatment. So it would fit into a very large body of research on that topic.
So I would say that, the effect was 6.4% for the county, at the county level, 20% if you focus on the zip codes nearest to the clinics. And that's happening against a backdrop where across the U.S., say the teen birth rate has fallen by 40%. So, 6%, you can explain 6% of that massive decline as being a result of this initiative. So other things are going on in the background that are really pushing unintended pregnancies down. Certainly, though, these sorts of initiatives appear as if they can push them down even further. But understanding what else is it, and what is it that's causing these birth rates to go down all across the U.S., even in places where these initiatives aren't happening, is something that I think is really important for researchers to dig into and to better understand.
So, Mark, I have one of the things we did, so we've done a couple of things trying to think about how do you compare the value of a dollar spent on family planning to, say, the value of a dollar spent on federal aid for college in terms of increasing college graduation rates. We did a variety of calculations like this in sort of our Brookings piece, so you're welcome to take a look at that. That has some hard numbers. And the other thing that we did is sort of increasing the resources for children. Say, for instance, as a policymaker, you want to target a reduction in poverty. What's your best bet in terms of program? What's the most cost-effective way to reduce child poverty by a point, by 5 percentage points? How would you do that? Family planning wins by a lot relative to other public programs that are funding that as well. So that's also in a paper that's I can provide you the link to after this session.
Okay, thank you, members of the panel. And now, Belle, for the final word. We'll get out of your way first, Belle.
Oh, no, just stay there, because I'm going to be very brief. I mainly want to really thank everybody. You all were terrific, and I've been so excited about this whole event, and I really think the story that came out is an important one, and we are going to do what we can to use our megaphone here to get it out even further. What was the story? Let me try to give you my very quick, short takeaways. On panel 1, we learned that there are some states that are doing some great stuff, and they seem to be accomplishing their purposes. It takes leadership. That means a governor like Governor Markell. It takes partnerships like between upstream and the state of Washington or the state of Delaware or wherever. It takes changing practice and changing bureaucracies in the health system. We heard about that. So it isn't easy. It's hard work. It's got to be kept going. It's got to be sustainable. I'm glad the sustainable question came up, but I think this is a very positive story. Panel 2, we heard more about what I like to think of as the demand side. As someone in the audience asked early on, how do we get people, get women in particular, to come to the clinics to get services that we're able to offer? And I think what you heard in panel 2 is that if you give people good information, such as like through bedsider, for example, that helps a lot. If on top of that you say, you've got to think about your future, you've got to think about pathways to power, as Ian puts it. You've got to do as Dr. Tilden Burton said to one of her patients, what do you want to do with your life? That I thought was just a wonderful little anecdote that she told, that this client of hers, patient, I guess I should say, had never had anyone in her life say to her, what do you want to do with your life? And if you offer same-day services to make it easy for people, you can, and if you have OBGYNs that are as dedicated as Dave Turok or the others we've heard from today, it makes a big difference. And then finally, this research panel, I think, has showcased some of the best research in the country on these issues. As we said earlier, there isn't enough of it, and we need more, and the data aren't great. But I think we, at this stage, know enough to know that this kind of approach can work. That if we had more Title X dollars, it would be good. If we had more efforts in the states that we've talked about, it would be good. And that we don't know as much about the long-term effects, but as Martha so well pointed out and as her research has so well shown, there are likely strong long-term effects on both children and adults. So thank you all for being here, and stay tuned.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.